Hello, my name is Ashley Covert, and I'm a graduate student at Kaiser University. Today, I'll be discussing a topic that is both professionally relevant and deeply personal to many of us, the role of physiological and psychometric tests in trauma assessment. We are going to explore how trauma affects both the mind and body, and how we use various scientific tools and instruments to better understand, diagnose, and treat these effects. Over the next few slides, we'll explore the history of trauma assessment, the tools we use today, and the ethical, cultural, and societal implications of using them. By the end, I hope that you'll see just how vital these assessments are, not only in guiding treatment, but in validating survivors' experiences and helping them reclaim control over their lives. Let's begin by discussing what is trauma. This slide gives us a foundation for understanding trauma, what it is, where it comes from, and how it affects people. First, let's define it. Trauma is the lasting psychological, emotional, and physiological impact of overwhelming experiences that exceed a person's ability to cope. It often leads to persistent distress, dysregulation, and impaired functioning, especially when someone feels helpless or unsupported during or after the experience. Trauma can result from many sources, not just direct harm. It might stem from a single overwhelming event like an accident or an assault, indirect exposure, such as what first responders or caregivers experience, or long-term adversity, like childhood abuse, neglect, or repeated instability. The effects of trauma can show up in multiple systems. It impacts the brain and nervous system, often altering how we process stress. It affects emotional regulation, making it harder to feel safe, stable, or in control. And it changes behavior and physical health, sometimes in ways that aren't obviously connected, like sleep issues, chronic pain, or avoidance behaviors. Common trauma responses include disassociation, feeling disconnected from your body or surroundings, hypervigilance, where the nervous system is constantly on high alert, and chronic pain, which can be a physical echo of emotional overwhelm. And as the quote on the slide from Judith Herman reminds us, psychological trauma is the affliction of the powerless. At the moment of trauma, the victim is rendered helpless by overwhelming force. This quote captures the heart of trauma, not just what happened, but what it felt like in the moment: helplessness, overwhelm, and a body wired for survival. Understanding trauma this way helps us assess it more compassionately and more effectively. This slide offers a comprehensive overview of why trauma assessment is important, what it entails, and its practical implications for clinical practice. Let's start with the reality. Trauma is widespread and often overlooked. It affects people across all backgrounds, whether through direct experiences, systemic harm, or vicarious exposure. Yet trauma is frequently underreported, especially when symptoms don't look like classic PTSD. Instead, they often present as anxiety, depression, emotional dysregulation, or even physical symptoms. According to the research, over 70% of adults globally have experienced at least one traumatic event in their lifetime, and trauma disproportionately impacts marginalized populations like refugees, military veterans, and survivors of domestic violence. Next, we look at the role of trauma assessment. Effective trauma assessment helps identify and quantify trauma symptoms, guiding clinical understanding of how trauma is affecting someone's functioning. It plays a critical role in differential diagnosis, helping us distinguish trauma from other conditions like anxiety, depression, or personality disorders. It also supports the development of individualized trauma-informed treatment plans and provides a framework for ongoing monitoring of symptom progression. Perhaps just as importantly, it offers a validating experience for the client, helping them name and understand their suffering. In terms of clinical and professional value, trauma assessments corroborate the lived experiences of survivors, support legal and forensic processes like disability or compensation claims, inform school-based and behavioral support systems, help clinicians diagnose more accurately, especially when symptoms are complex, and assist in early identification of individuals at higher risk for serious psychological distress. So, trauma assessment isn't just a formality. It's a powerful clinical tool that bridges understanding, treatment, and healing. Why does trauma matter? The answer is both straightforward and urgent. Trauma is pervasive and its effects are deeply significant. Trauma doesn't always manifest with visible scars. Many individuals suffer in silence, grappling with symptoms such as anxiety, flashbacks, disassociation, and hypervigilance without ever receiving a diagnosis or support. For those who do develop PTSD, affecting about 5 to 8% of the global population and up to 15% in those exposed to conflict, the ramifications can be life-altering. PTSD can impact relationships, physical health, employment, and overall quality of life. In the United States, nearly 8 to 10% of people will experience PTSD, with women twice as likely to be affected as men. The encouraging news is that trauma is treatable, and this is where proper assessment plays a critical role. Trauma-informed assessments are essential. They help differentiate between normal stress responses and clinical disorders, validate lived experiences, and, most importantly, facilitate healing. In our current reality, marked by global conflict, mass violence, pandemics, and significant loss, trauma-informed care is not merely optional, it's indispensable. Trauma matters because people matter, and the way we assess it reflects how profoundly we honor this truth. Here are the key milestones in the development of trauma assessment. Ancient texts found documented descriptions of trauma-like symptoms by Homer and in spiritual literature. In the late 1800s, Freud introduced psychoanalytic theory, linking trauma to the unconscious, while Pierre Janet documented disassociation in trauma survivors, laying the groundwork for psychological trauma theory. During World War I, the term shell shock emerged, marking the first large-scale recognition of combat-related psychological trauma. In the 1930s and 1940s, projected tests like the Rorschach inkblot test and the TAT were developed to explore unconscious trauma responses. Post-World War II, in the 1945 through 1950s, the field saw emergence of structured clinical interviews and broader use of psychometric tools, especially for veterans, pushing the need for standardized assessments. Psychometric foundations introduced the MMPI and the Rorschach were used to explore trauma responses. In 1980, when PTSD was officially recognized in the DSM-3, it changed the game. Trauma was finally seen as a legitimate mental health diagnosis, not just a character flaw or personal weakness. In the 1980s and 90s, we saw the development of early structured tools. The Mississippi Scale was one of the first, designed for combat veterans. Then came the SCID and CAPS interviews, more formal clinician-administered assessments. Around the same time, self-report tools like the PCL checklist started gaining ground, making it easier to screen for PTSD symptoms. Moving into the 2000s and 2010s, things got more sophisticated with the rise of biopsychological integration. We started looking beyond symptoms to the body, measuring things like heart rate variability, cortisol levels, and startle responses. There was also growing interest in neuroimaging and the brain-body connection, especially in understanding comorbidities and trauma severity. In 2013, the DSM-5 redefined PTSD. It was reclassified under trauma and stressor-related disorders, and new symptoms around negative mood and cognition were added. This helped make diagnosis more accurate and reflective of lived experience. And today, we're in the era of global and integrated approaches. Assessments are being translated and validated across cultures and used in a range of settings, from clinics to refugee camps. There's a strong push for trauma-informed, culturally competent, and multimodal assessments that combine both psychometric and physiological tools. It's not just about diagnosis anymore. It's about meeting people where they are, understanding their full context, and supporting healing in more holistic ways. Here is an overview of several of the most widely used psychometric tools in trauma assessment, all of which rely on standardized self-reports or structured interviews to measure physiological symptoms related to trauma. First, the PCL-5 is a 20-item self-report checklist aligned with the DSM-5 PTSD criteria. It's quick to administer, uses a 0 through 4 Likert scale, and is commonly used for screening, diagnosis support, and symptom monitoring. The CAPS-5 takes it a step further. It's a structured clinical interview conducted by a trained professional and is considered the gold standard for diagnosing PTSD, offering detailed symptom profiles and severity ratings. Next is the TSI-2, a broad spectrum tool with 136 items. It evaluates a wide range of trauma-related symptoms like anxiety, depression, and disassociation. Its comprehensive format makes it ideal for treatment planning and deeper assessment. And then there's the DES, which screens specifically for dissociative symptoms, often overlooked but very common in trauma survivors. These tools are essential because they provide direct insight into a person's lived experience. They're also cost-effective and accessible, especially compared to physiological tests, making them invaluable for early screening and planning effective, individualized care. There are several physiological instruments used to assess how trauma affects the autonomic nervous system, which controls involuntary responses like heart rate, stress hormones, and arousal. These tools provide objective data, often revealing trauma-related dysregulation that might not be visible through observation or self-report alone. Let's look at a few key examples. Heart rate variability, HRV. HRV measures the variation in time between heartbeats. Lower HRV is often seen in people with PTSD or chronic stress and reflects poor emotional regulation. It's commonly used to assess baseline stress levels and monitor treatment response over time. Skin conductance response, SCR, also known as electrodermal activity, EDA. This measures sweat gland activity linked to sympathetic nerve system arousal. Trauma-exposed individuals often show heightened responses to emotional or threat-related stimuli. It's used in fear conditioning and arousal studies. Cortisol testing, saliva, blood, hair. Cortisol is a key stress hormone from the HPA axis. In trauma survivors, we often see dysregulated patterns. Some have elevated levels, others show blunted responses. It's useful for understanding stress reactivity and the long-term physiological effects of trauma. fMRI and PET scans. These neuroimaging tools show how trauma alters the brain function, such as amygdala hyperactivation and reduced activity in the prefrontal cortex. While primarily used in research, they help us understand how trauma rewires the brain. Now let's investigate reliability, validity, and constructs measured by some of the most widely used psychometric tools in trauma assessment. Starting with the CAPS-5, the Clinician-Administered PTSD Scale. It measures all DSM-5 PTSD symptom clusters and is considered the gold standard for PTSD diagnosis. It has a high inner rater and test-retest reliability and its strong construct validity. Next, the PCL-5, the PTSD checklist. This is a self-report tool that captures symptom severity over the past month. It's known for excellent internal consistency and is valid for both screening and tracking symptom change over time. The TSI-2, or Trauma Symptom Inventory 2, assesses complex trauma symptoms, including disassociation and somatic complaints. It shows strong reliability across subscales and is a valid tool for comprehensive trauma symptom evaluation. Then we have the DES-2, the Dissociative Experiences Scale. This screens for dissociative symptoms such as depersonalization and amnesia. It has a good internal consistency, but its validity improves when paired with clinical interviews. Lastly, the BDI-2 or Beck Depression Inventory. It measures cognitive, emotional, and somatic symptoms of depression. It is highly reliable and valid for detecting trauma-related depression, though it's not trauma-specific. Together, these tools offer a solid foundation for assessing the range and severity of trauma responses, each with strengths depending on the population and clinical setting. Next, let's explore the key tools in physiological instruments and the role they play into trauma assessment that objectively measure biological markers linked to trauma. Unlike self-report methods, these tools capture the body's reactions to perceived threats, even if the mind tries to suppress them. Here's an overview of primary physiological instruments used to assess trauma responses and their role in understanding the body's reaction to danger. Consider the following examples. Heart rate variability, HRV, demonstrates high reliability under controlled conditions and is strongly valid for assessing dysregulation of the autonomic nervous system, a condition frequently observed in individuals with PTSD. Cortisol testing, conducted via saliva or blood samples, exhibits moderate reliability due to natural biological fluctuations. However, it retains its validity for identifying chronic stress and dysfunction within the HPA axis. EEG and fMRI employ sophisticated techniques and offer strong validity. EEG is adept at detecting alterations in brainwave activity, while fMRI is effective in identifying trauma-related changes in brain regions such as the amygdala. Both modalities demonstrate general reliability when standardized protocols are applied. Galvanic skin response, GSR, and startle reflex assessments present moderate reliability. These measures evaluate physiological arousal and hypervigilance, key indicators of trauma, yet they are susceptible to external influences. Thus, they are most effective when integrated with other data sources. No single instrument is flawless. It is the combined application of these instruments that yields significant, quantifiable insights into the impact of trauma on both physiological and neurological functioning. Trauma assessments are used across a wide range of settings, each with its own purpose and priorities, but all with the shared goal of understanding and addressing trauma effectively. In clinical settings like therapy offices, hospitals, and private practices, assessments support diagnosis, treatment planning, and symptom monitoring. Psychometric tools are essential here, helping clinicians evaluate mental health, behavior, and risk over time. In research settings, such as universities or institutes, trauma assessments are used to validate tools, measure treatment outcomes, and explore the neurobiology of trauma. Both physiological and psychometric measures are often combined to gain a deeper scientific understanding. In forensic and legal settings, trauma assessments play a key role in competency evaluations, disability claims, and detecting malingering. The use of objective physiological data alongside validated psychometric tools helps ensure fairness and accuracy. Military and first responder contexts rely on trauma assessments to evaluate readiness, screen for exposure, and identify those in need of early intervention. These assessments can be critical for maintaining both individual well-being and organizational readiness. And finally, the common purposes of trauma assessment span all these settings, from early screening and formal diagnosis to guiding therapy, evaluating risk, informing legal decisions, and shaping public health research. These tools aren't just clinical, they're foundational to trauma-informed systems at every level. When we assess trauma, it's not just about choosing the right tools, it's about how we use them. Let's outline the ethical, cultural, and societal considerations that must guide every trauma assessment. First, we have ethical considerations. These include obtaining informed consent, practicing harm reduction, protecting privacy, and avoiding pathologizing normal trauma reactions. In other words, we need to assess with empathy and respect, not judgment. Next are cultural considerations. Trauma doesn't look the same across all backgrounds. We must consider cultural norms, adapt tools through accurate translation, and recognize that some individuals may express trauma through physical symptoms rather than emotional language. Culturally responsive assessments are more accurate and more humane. Finally, there are societal considerations. These include reducing stigma, addressing disparities in access to assessment and care, and being mindful of broader issues like resource limitations and systemic barriers. Not everyone has the same opportunity to get help, and trauma-informed care must account for that. At its core, ethical trauma assessment is about meeting people where they are, physiologically, culturally, and socially, and doing so with compassion, integrity, and fairness. Trauma assessment transcends mere clinical evaluation. It's a profound act of acknowledgement. By employing both physiological and psychometric tools, we gain a comprehensive understanding of trauma's effects, enabling more accurate diagnoses, effective treatment planning, and respectful support for survivors. Integrating diverse assessment strategies not only enhances diagnostic precision, but also facilitates the creation of individualized, evidence-based interventions that foster long-term healing. However, tools alone are insufficient. Ethical practice, cultural sensitivity, and equitable access must guide their use, recognizing the humanity behind every checklist or heart monitoring reading. Effective trauma assessment is the cornerstone of effective trauma recovery, laying the foundation for meaningful healing at both individual and societal levels. As future clinicians, researchers, and advocates, we have a responsibility to ensure our assessments don't just measure trauma, they help heal it. Let's move forward committed not just to evidence based practice, but to survivor centered care. Thank you.